here in Saudi Arabia, in Riyadh, and get to spend a couple of days with you. And so I think the idea was this is talk about upper tract disease and continuing on the kidney theme. And I must say, Dr. Gill is an awfully tough act to follow. The level of technical skill and expertise that you see. I've seen this for probably 2 decades now, just listening to him, and so I really appreciate all that. So what I'm going to do, hopefully in about 20 minutes, is talk about upper urinary tract, so ureter, renal pelvic tumors, and try to help us all sort of come away with an understanding of identifying patients who are appropriate for kidney preservation surgery and some strategies of how to deal with particularly tough to treat renal pelvic disease. I figured with my first talk I'll tell you a little bit of where I'm from. Obviously Houston, Texas. This is the Texas Medical Center. We like things big in Texas. It's the largest medical center in the world, I believe. It's an extraordinary place to work, and this is our sort of new campus, the vision for the future, 600-bed acute care hospital, and this is where we've been working in our clinics now for several years. So it's exciting to be there. I'll show this slide again tomorrow. I am going to talk a little bit about a trial that I'm the scientific lead on from Eurogen. I do have compensation for that role, and I've served as a consultant for them. The rest of this I won't be talking about with this particular talk, and I'll come back to this tomorrow with the rest of my talk. So just a little bit about upper tract disease. Not surprisingly, men more common than women. You see the ratio is a little lower than you typically see for bladder cancer, which is more like 3 to 4 to 1. And it's a disease of elderly patients. It doesn't mean that we don't see younger patients, but this is largely disease of elderly and lots of comorbidities, which I'll talk about briefly. And the mix of renal pelvic to ureter is roughly about 60 to 40, at least in the latest SEER data. And so renal preservation becomes really important to think about, and I think it's highly relevant with state-of-the-art HD, blue-chip cameras where you can really see much better, with much better clarity. And I think the tools that we have allow you to do a lot more and sort of push the envelope in terms of renal preservation. So this is some publicly available data looking at chronic kidney disease by age and risk factor. And along the x-axis, obviously diabetes mellitus, SR is self-reported diabetes, same for hypertension and self-reported cardiovascular disease and BMI. And what you can see is that the percentage of patients, and particularly older patients, these are the comorbidities that are going to have an adverse impact on total renal function and drive some of the decision making for renal preservation. And then if you look at all-cause mortality in patients with end-stage renal disease, you can see the powerful impact of age. And these are things that we as urologists know quite well. And so taking a 65 or 70 or even older patient and putting them on dialysis or putting them near dialysis is going to have a profound impact on their overall quality of life and potentially shorten their long-term survival. And so it's imperative that we have a very healthy understanding of lethal phenotypes of upper urinary tract tumors and identify those patients that are not going to be really put in harm's way by a nephron-sparing procedure. Now, from the outset, it's important to understand that for mid and proximal ureter and renal pelvis, high-grade cancers, that radical nephroureterectomy is the standard of care, and I'll also put out there that an ipsilateral retroperitoneal node dissection should also be included in that. So we have to have lots of good reasons not to do that. And having said that obviously reducing the renal function by half is going to put the patient at risk for chronic kidney disease compared with nephron-sparing techniques, and these are some of the risk factors I think that all of us are familiar with. Certainly age, comorbidities, a high BMI, and smoking, at least in this study, were independent risk factors for progression to chronic renal insufficiency after surgery. And what you see also, the challenge is that now that we know We have high-level evidence from 2 large randomized clinical trials of the benefit of neoadjuvant chemotherapy and in the setting of invasive bladder cancer. A lot of groups are taking that knowledge and applying it to upper urinary tract disease, where we have patients that say 3 centimeters or larger tumors, sessile tumors, biopsy-proven high-grade disease, and offering neoadjuvant chemotherapy in that setting. And it's really important to consider that in appropriate patients, because when you reduce the renal function by half by taking out a kidney, you're going to reduce the probability that that patient's going to be eligible to get cisplatin-based chemotherapy in the postoperative or adjuvant setting. And so I think the things that we want to try to avoid are doing an nephrectomy for, say, a high-grade tumor that has positive nodes, knowing that without additional therapy, that patient probably has a life expectancy maybe 25% at 5 years at best. So these are some of the things that we've been thinking about for quite some time. This is a nice study from Dr. Zailinas from Greece, who I've gotten to know quite well. And you look at the effect of just the stratification of EGFR above and below 60 and overall survival, so just a straight univariate Kaplan-Meier analysis preoperatively and then postoperatively. You can see in both settings there's a profound impact just on the reduction of EGFR in overall survival probability. So this is what I feel and the guidelines would support. This is the EAU guidelines and NCCN guidelines, and we'll talk a little bit about ICOD as I move along in the talk. So just as Indy taught us about the imperative indications for a partial nephrectomy, a lot of those same conditions exist in terms of dealing with upper urinary tract tumors. So chronic kidney disease, where if you take a kidney out, the patient's going to go on dialysis, would be one. Any bilateral disease that's affecting both kidneys, obviously a functionally or anatomic solitary kidney. It's interesting when you're dealing with that, it drives you down a pathway of doing some perhaps unconventional techniques such as percutaneous resection of renal pelvic tumors. And then if you sort of expand those indications, then certainly small volume low-grade disease. We're not averse to 2 and 3 procedures to try to get rid of even large volume low-grade disease, where we think renal preservation is important. I would argue, and I suspect that you'd agree with me, that low-grade disease confined to the distal ureter standard of care, if you can't manage that endoscopically or glacier, should be a distal ureterectomy and appropriate reconstruction, usually with a psoas hitch reimplant. And then sort of the interesting observation, if you have a patient who's got a complete response by biopsy, cytology, and cystoscopy who got neoadjuvant chemotherapy, there may be settings in there where you may decide not to go ahead with a nephrectomy. That would be a little bit unconventional. It would require strong multidisciplinary evaluation before going down in that direction. I think this group doesn't need an education on diagnosis and staging, cross-sectional imaging with CT urography. MR urography is also an option in patients who have iodine contrast allergies. I think the state-of-the-art in terms of endoscopic equipment and tools that we have to deal with are making direct visualization and treatment a lot simpler. And then there's, we use PET-CT to adjudicate really extra-renal issues. So for instance, if you see adenopathy and you're concerned about metastasis, PET-CT may be helpful in that setting. So some of the drivers are this incredible experience that we're all getting in terms of renal preservation for renal cell carcinoma, and the technology that we have available in terms of access sheaths and just the general sort of tool shed that we have to do things, quite frankly, that I've got some gray hair on my head. I'm 25 years out from my training, and I grew up in the era of these 11, 13 French rigid ureteroscopes. This is a different era. You can do this in the clinic, even just for diagnostic or following patients with these small, thin, flexible ureteroscopes. And then we'll talk a little bit about adjuvant topical therapy. So there's some things that we need to consider that might present as challenges and limitations. So A high-grade cytology, so if anytime you're working particularly in the renal pelvis, you want to do a wash cytology, which should be pretty sensitive for high-grade disease. So if you have a cytology that's showing high-grade malignant cells, and you've got a high-grade cancer independent of what the biopsy may or may not show. Biopsy, I think, is always important to try to do. We all know that technically it's not always feasible, but a high-grade biopsy basically is going to be highly concordant with final pathology at the time of resection. And I think the other thing is that it's very hard, as you know, to really stage and determine invasion, really in the renal pelvis or the ureter, particularly if your cross-sectional imaging doesn't suggest a mass that's outside the ureter or invading the kidney. But a high-grade biopsy, high-grade cytology is going to be associated with a higher risk of a T2 or T3 tumor. And I think the literature would support, and experience would support, that just direct visualization alone is not going to be as accurate in terms of adjudicating low-grade and high-grade disease, and oftentimes will understage or undergrade the tumors. So we really need to, at a minimum, directly visualize, get a cytology, and whenever possible, get a biopsy, independent of the final treatment plan. So I mentioned this at the beginning, and I think the first time I did this was an 81-year-old gentleman who had a previous nephrectomy on the contralateral side for renal pelvic tumor, and he presented with a large volume, ended up being T1 high grade, and I did 2 or 3 percutaneous resections because the volume was too great to manage with a conventional ureteroscopy. And we're actually able to help this guy keep his kidney for a few years. He ultimately made a decision at his age, advanced age, not to have his kidney out, despite me sort of telling him, you gotta have your kidney out. He ended up with metastatic disease, but he didn't go on dialysis ever and enjoyed about another 3 or 4 years of life. So it can be palliative, right? But it can also be therapeutic and something to consider in terms of percutaneous resection. Now, we've talked a little bit about already the idea of just a segmental or partial ureterectomy. Generally don't recommend this for high-grade disease in the mid or proximal ureter, but I have had situations where I've had ureteral-only disease. And remember, you can go in and just do a total ureterectomy and take a segment of ileum and make an ileal ureter to reconstruct that if you have a compelling reason to save the kidney. And that might be in a situation where you've got a locally advanced tumor, let's say maybe a positive node, where you know that you want to give them chemotherapy. And so in that setting, it's good to try to save the kidney. And in this setting, those outcomes are going to be quite similar to a radical nephroureterectomy. So here's a case, a woman in her mid-70s. I treated her for low-grade disease in the bladder. I've gone through the panoply of drugs. She also had a distal left ureteral tumor, and I performed a left nephroureterectomy for a large volume TA low-grade. So she's looking at a solitary tumor in her right, in her remaining kidney on the right renal pelvis. I went through everything I could to try to clear the kidney. And ultimately, this lady is the first patient I've ever seen with a low-grade, biopsy-proven low-grade lung metastasis, solitary metastasis. Never occurred to me that you could have a low-grade metastasis. But subsequent to that, we diagnosed her with high-grade disease in the kidney and ended up having to take her kidney out. Let's talk a little bit about the risk. This patient also was an example of maybe we waited too long to take the kidney out. So here's a study of just under 200 patients, and the delay in radical nephroureterectomy was associated with advanced stage necrosis, which is a poor prognostic feature, lymphovascular invasion, and however, the delays in this study did not correlate with reduced recurrence-free or cancer-specific survival, except in the setting of invasive cancer. So we have to be very careful in balancing the desire for nephron sparing, the potential delay in definitive treatment with a nephroureterectomy, and the risk of upstaging and reducing the probability of survival. This is a nice meta-analysis that was published a couple of years ago. look, the level of evidence is not that great. High-grade disease ranged from 23 to 73%, and comparing a nephroureterectomy to endoscopic approaches, there was no difference in overall or cancer-specific survival. So quality of the data is not all that good, and we don't have randomized comparisons, but at least there's some data out there to suggest that from a cancer standpoint, this may be safe. So we're interested in a couple of different outcomes in addition to the obvious of survival and progression with metastatic disease. So in comparing the incidence of local recurrence, so this would be either in the ureter or the renal pelvis, and bladder recurrence, you see that there's not a lot of difference. The range is really quite high. And I don't mention it in this talk, but it's worth saying that there's level 1 evidence in terms of reducing the risk of bladder recurrence by giving a single dose of intravesical chemotherapy, usually within about 7 to 10 days of whatever the procedure is that you've done, whether it be a distal ureterectomy or a nephroureterectomy. Big randomized trial in the UK, randomized trial in Japan, and I can tell you in the US, a lot of us have adopted this, and typically we'll give the chemotherapy at the time that we take the catheter out of the bladder, assuming that we leave that in for 5 to 7 days. And that statistically reduces the risk of recurrence in the bladder. So there's some guidelines from the EAU. This was the first group to put out guidelines, and you can see here at the bottom, grade B evidence. So small unifocal tumors, low-grade tumors, nothing really evident on cross-sectional imaging suggesting invasion. And obviously, these patients now are going to go into close surveillance. What's close surveillance? I'll often take them back the first time at about 3 to 4 months, and then I'm scoping them every 6 months. And if they stay disease-free for about 2 years, I'll extend that out to about a year. And at least for us, we have to do all of those in the operating room under anesthesia. So it's not as simple as the patient that, you're doing flexible cystoscopy, in the outpatient clinic every 3 months for high-grade disease. So you have to be able to stay on top of these patients. I was involved in the ICUD guidelines panel. I think this was published in 2016, and the ICUD guidelines does address renal preservation and suggests that it is an option for patients with high-grade disease, and particularly in the distal ureter. So I'll do distal ureterectomies for high-grade disease as well. I really do not like taking out a normal kidney and mid and proximal ureter for something that's isolated to the distal ureter. But I think I've got a case in here that's going to show you where that backfired. But remember, for high-grade disease, it's not necessarily standard of care, but I think it's reasonable approach in selected patients. And the first bullet point addresses that. And then, when you're dealing with high-grade disease up in the renal pelvis, and you're going to do nephron sparing, and you can ablate it all, you're not done. You have to be able to administer intracavitary therapy just like we would do in the bladder. You can use BCG, you can use mitomycin, for example, and I like mitomycin for low-grade disease and BCG for high-grade disease when I'm in a nephron sparing mode. And this is just a Cochrane review that addresses the same thing, and what you can see is that the level of evidence, again, is not where we would like it to be as a community. So I think in that setting, we have to have a very thorough, informed consent with the patient so that they understand what the risk and potential benefit of in terms of renal preservation. So to summarize this part of the talk, there's some very clear imperative indications, and that would basically mirror the imperative indications for a partial nephrectomy for renal cell carcinoma. We've described some elective or non-imperative indications. The evidence isn't quite good, and obviously we'd like to have higher level evidence from prospective trials. So the second part of this is to help us understand a little bit about intracavitary therapy. So we've now made a decision for nephron sparing. This is relatively new stuff. Actually, Jeff Huffman, who is a USC faculty, still at USC, right? Jeff was really the first to describe this, and not that old in terms of the approach. There's a variety of ways you can deliver this. You can certainly do it through a nephrostomy tube. I'm going to show you that we've kind of moved to putting ureteral catheters up in the clinic as opposed to leaving a nephrostomy tube in for 5 or 6 weeks. And there's also a fairly clever technique that's published that you can do it suprapubically. Put in a small little single J stent through a suprapubic. You can use a variety of different drugs. I realize that there's things that we might have available in North America that may differ in other countries. So there's a host of options for you for both chemotherapy and intravesical immunotherapy. The guidelines address this. Again, level of evidence would be 3. I would say that for certainly papillary high-grade disease that you completely resect, carcinoma in situ, those patients all ought to get a run at intracavitary therapy. We've addressed that already. I want to make it abundantly clear that you cannot treat the upper urinary tract by giving BCG in the bladder in the setting of a double J stent and hope that that's going to treat your renal pelvic tumor. You may get some benefit in a distal ureteral tumor, but I hear this a lot, I see it a lot, I've scanned the literature, I've never seen any. There actually is a study from Japan that suggested it might actually work. But I think that you really have to be able to directly deliver the drug to the renal pelvis. And I don't know how to treat the ureter with an intracavitary installation, but I'm going to show you some cool technology that might allow us to do it in the future. And there's a Japanese study that suggested in a small number of patients that it might actually work. This is just a schematic of how you might do it. There are a couple of really important caveats, and I think there's 2 of them. Please always verify that the collecting system, you got a negative urine culture. And then the second thing is that you really have to be quite careful, especially in the setting of BCG, that you control the intracavitary pressure at 20 millimeters of mercury. There have been some very well documented cases of death from intravascular BCG when high pressures were allowed to occur up in the renal pelvis. So it's a little tricky. You see here what we're using is a lumbar puncture sort of manometer here, set at the level of the kidney, and it's not trivial. It's sort of, in America, we call it the proverbial dog and pony show, meaning it's hard to get organized. But once does anybody do this? Sorry, raise your hand if you have experience with intracavitary therapy. Okay. You're sort of like me. It's not my favorite thing to do, but I think it's really important if you're going to go down the renal preservation strategy and you don't have an invasive cancer or otherwise reason to take the kidney out. Now, I'm happy to leave these slides with you. If you're interested, this technique is published. It's not our original technique. We adopted it. But there's a very clever way of threading a single J stent that goes kidney, ureter, obviously out suprapubically. And that may be an alternative, a good alternative to a percutaneous, leaving a percutaneous nephrostomy tube in throughout the entire treatment cycle. And so we've done this in the past, but as I mentioned, we're sort of moving more towards just putting up a ureteral catheter at the time of the installation. Weekly for 6 weeks. These are just some data looking at BCG. The majority of patients had CIS, and you can see the outcomes here for both recurrence-free survival and nephroureterectomy-free survival. So it does, at least in the studies that I've looked at, appear to have a benefit in terms of certainly delaying those 2 events, and then really key in terms of reducing the risk of progression, which would obviously something we all want to avoid before, we don't want to be taking a kidney out with a T3 node positive tumor. So this was a nice paper published in World Journal of Urology a few years ago, looking at post-resection Ta-T1 adjuvant therapy. Again, kind of a modest number of kidneys, and you can see this wide range of recurrence rate after BCG, and the largest series showed about a 1/3 recurrence rate 5 years out. That's actually not too bad for high-grade disease. I think that most of our patients would be accepting that. And then with CIS, obviously we're treating that, and the intent is to get rid of it completely. And I've had some success with this, and you can see here it's also reflected in this particular review of 12 series. This is what I was referring to before in terms of single-dose perioperative mitomycin C. So just to remind you that this is in a setting of doing a distal or a subtotal ureterectomy, or really any kind of excision treatment, nephroureterectomy, where we know that there's at least a 40% probability of developing a tumor in the bladder within 2 years, and there's a statistically significant reduction in incidence of that, in this case using mitomycin C. So the last few slides are around a technology. This is what I mentioned at the beginning, that I'm involved with a clinical trial that I'm going to show you about very briefly. And so in the bladder, when we're testing new drugs, there's a very strong evidence-based rationale for leaving a 1 centimeter or less low-grade tumor in the bladder, using your drug, and using disappearance of the bladder, disappearance of the bladder tumor as a marker for proof of concept of efficacy of your drug. And virtually every drug that we use in the bladder has gone through this clinical trial process. And so the question is, can you apply that up in the upper urinary tract and even take it a bit further as a chemoablation strategy? So as opposed to, let's say I've got large volume disease, for instance, low-grade disease, that I can't get rid of completely, endoscopically, laser, whatever technique. Here's a strategy that may be able to take a chemoablation by putting a drug up there that's intended to treat the residual tumor. So I want to just tell you about MitoGel. So this is a product that's developed by this company, Urogen, and it basically takes a fairly simple chemistry. So think about it. Is anybody, you familiar with this product, Backstop? The endourologist, the thermoreversible gel. So you put this, so this gel, it's the same identical technology. It's liquid at, not quite sort of a viscous liquid at room temperature, and at body temperature it forms a semi-solid material that as urine production occurs, it dissolves. So what you do is, in the setting of stones, where you don't want stones to migrate up into the renal pelvis, you put a catheter above it, inject the stuff, it's literally a backstop, treat your stone, and then irrigate to dissolve the gel, and presto, you're done. So same identical technology, but now mixed with mitomycin at typical doses from anywhere from 40 milligrams to 80 milligrams. And so this is how this works. This is just the two little pictures on the right showing you that it forms this solid at body temperature. So this is a case of Gregory Wirth, who works in the Geneva Hospital in Switzerland. So remember I talked to you, it might in the future be a strategy for ureteral tumors. And so here you see very obvious filling defect. Endoscopically you see this tumor here. And they treated this patient with 6 weeks of this MitoGel preparation, and the patient had a complete response. So chemoablation. And this was part of a compassionate use protocol that I've described here. We put 2 patients on this protocol. There have been a number of patients treated in the US and other countries. And the cool thing is that for the patients with low-grade disease, the efficacy was actually quite good in terms of ablation. Now, we're not treating large tumors in this setting yet. And so this is a patient of mine, a different patient than I presented before, remote history of a left nephrectomy for an angiomyolipoma. And I treated him for a long time with TA low-grade disease in the right pelvis. The first time I diagnosed him, I couldn't quite get rid of it, and I told him I thought his kidney ought to come out, and he said, "You're not going to take my kidney out." So that was in 2007. He still has his kidney, interestingly enough. And we tried a couple of things, Mito, BCG, and then he had this picture here. So this is not anything that's going to hurt this guy. It's small volume, got a little bit of necrosis on it. biopsy-proven low-grade disease, and after 6 weeks of mitogel, it's pretty much all gone. What you're basically seeing is a necrotic tumor bed, and he's probably now about a year out and hasn't had any recurrence. So what the clinical trial is, the study design is here. So what's really exciting about this is that the FDA set an incredibly low bar for approval, basically taking a TA low-grade tumor anywhere from 5 millimeters to 15 millimeters, biopsy-proven, normal cytology, treat weekly for 6 weeks, 74 patients. If we have an efficacy rate of 15%, we've got an approvable drug. Why is that? Because it's a huge unmet need. Not a lot of patients, right? It's a relatively rare disease in terms of all the things that we take care of. But this trial is actively enrolling, and I think we've got about 15 to 20 patients on right now. And so this is really exciting stuff that potentially is going to be coming down the pike. So in summary about intracavitary therapy, I think the drugs that we use most commonly are mitomycin, BCG, and just be very cautious when you're doing this to have a system where you can monitor pressures and remember to verify that the urine's sterile. And we are excited about the idea of being able to deliver mitomycin, in this case, for 4 to 6 hours. So remember, the problem is if you're instilling a drug up in the renal pelvis, it's going to go in and drain right out, no matter what you do. So contact time is limited, and mitomycin works off of concentration gradient. So you need to get it into the tumor, obviously, in this case of a chemoablation, you need to get it into the tissues, and you can only do that with the drug sitting around for longer than the length of the infusion. So that's the end of my talk. I'd be happy to take some questions, and then I think we will have some cases to discuss. So thank you very much.